Hi, everyone. I'd like to discuss an ECG today that I found on Twitter, and it was too interesting to actually just leave it aside. So as you can see, it's the Twitter handle for Dr. Andreas, I think it's Rochel. I stand to be corrected over there, but it's at ECG and Rhythm. So let me just get my point up over there at ECG and Rhythm ROE, ECG training. So if you have a chance, please go and follow them as well. I follow their page also, and it's really good. You do see a lot of interesting ECGs, and even though we cover a lot of them with our own patients, this was one I haven't actually seen from any of our patients in well over a few years. So I said it would be worth it to actually go through it with you guys. So it's quite an interesting one. I hope I do it justice. Let's go through it. So this was a 29-year-old female patient who presented to the emergency department with a history of palpitations. So when you look at this initially, it might look extremely scary and worrying, but once we break it down, you'll actually be able to at least get to a diagnosis. And once you get to a diagnosis, it's quite easy to check on causes and things like that. So as usual, let's just start with we're going to start with the axis, which may prove a bit tricky in this one. So let's just get our quadrants over there, and let's just get leads 1 and lead AVF going over there. Oops, sorry, it's going a bit off over there. Let's just try and put lead AVF. All right. So if we look at this now, what you need to know is that obviously there's an abnormal beat over here. So we're just going to look at the normal beats. And the normal beat is pointing upwards in leads 1. So we assume that the lead 1 is actually seeing electricity coming towards it. Sorry about that. So it's either in the normal or left quadrant. It's definitely not in the extreme right or right quadrant. And if we look at lead AVF, we can see both the abnormal beat and the normal beat are in the positive. So that means, sorry about that. Let me just get this properly. So that means the electricity that lead AVF is seeing is coming towards it. So since both of them coincide in the normal, we can say that this is a normal axis at least. Okay. Now we're going to get to the rhythm, which I think is the more interesting thing over here. So the first thing we've got to look at is our P waves. Now, they're not obvious in all the leads, of course, but in our rhythm strip, we can see them quite well. And we've actually got just about 1.5. So we've actually got a shortened PR interval. So this could be indicative of a re-entry abnormality or a pre-excitation syndrome. But in this case, I would go with the pre-excitation syndrome based on what we'll find later. So we've got a shortened PR interval. We don't have signs of some of the diseases associated with that, like Wolff Parkinson's White or LGL, Lugano, Levine, and things like that, but it's not so important for this discussion. If we look at our QRS complexes along our rhythm strip, they are quite narrow. But as you can see, a QRS doesn't follow every P. In fact, what we have is a P QRS and a T, and then we have a QRS, P QRS T, QRS, P, QRS, T. All right. And those batches are quite regular. In other words, the abnormal QRS followed by the P, QRS, T are actually occurring quite regularly. So your heart rate is actually between your two shortest QRS complex distances. So it's quite high. As you can see, it's about 175. So if you were to put your patient on a SATS monitor or on a rate monitor, you'd actually see the heart rate go like from 175 down to 120, back up to 175. It wouldn't give you a definitive reading. It keep on jumping up and down, which may even make you think of atrial fibrillation, which is another one that does that, but you would see it in this. So in other words, what we've got is a regular, irregular rhythm. So you're having pulse, pulse, gap, pulse, pulse, gap, pulse, pulse, gap. pulse cap. So that's what you would feel if you're feeling the patient's pulse. Now the question is, what are these? What is this that we are seeing over here? So what we see is a QRS complex without a P wave in front of it. So the atrium is not really involved here. It's the ventricle contracting on its own. So this is a premature ventricular contraction. And we see the premature ventricular contraction occurring before every single normal QRS complex. So this is what we call ventricular bigeminy. So it's occurring in a bigeminal pattern. Now you can get these in trigeminy as well, quadrigeminy. You could argue that normal QRS is a monogeminy, but this is definitely a bigeminy. And so you have a premature ventricular contraction followed by a normal ventricular contraction. So the question is, what's causing this? And that's what we've got to look at. Now, if we were to look at the rest of the ECG, it does become a bit interesting as well. Let's have a look at our inferior lead. So we look at our 2, 3, and AVF. And remember, your abnormal QRS complexes can affect your ST segments. But just looking at your normal QRS complexes, you can see some ST depressions over there. If you come to AVR, you can see a bit of ST elevations. If you come to V1 and V2, again, you start seeing these large ST elevations, which could also be benign, but in this case, they're not. And we can see some ST depressions here along our lateral and high lateral leads. So you could argue, okay, is there a bit of an ischemia going on? It's possible. However, it's a 29-year female. Could there be a block? Could there be something else that we're not seeing over here? So there's quite a bit that's going on. So these patients, now what are you going to do in the emergency department? The truth is that in the emergency department, you're going to take basic bloods, you're going to do your electrolyte workups, and you're going to get the physicians involved as quickly as possible. And the reason for that is because when we look at the causes, we can see electrolyte imbalances. So this is the most likely reason in a young person, although ischemia also can be part of it. But if we look at a young person, then you'd probably think of an electrolyte imbalance as probably the first one. So potassium, very likely, calcium, and even magnesium. So these are the first three that you would look at. Cardiac disease, underlying heart condition. So we did say there are signs of ischemia. So we would do an ischemic workup. Would you treat the patient for ischemia? No, I wouldn't start the patient unless they're having severe pain. I wouldn't start them on an ischemic protocol. So I wouldn't start them on Disprin. I wouldn't start them on any of the or thrombolize them or anything. I would have them ready, but this would be done under the supervision of a cardiologist or a physician because you don't want to thrombolize this patient unnecessarily, especially if then you find out the potassiums are a bit high and the calcium is just a bit high or magnesium is a bit high. It's very unlikely with the low levels. It's normally with the high levels. Hypoxia could also be a reason. So in this case, we don't have a patient with a respiratory disease, so it's possible. It's not really possible. Stimulants, consumption of caffeine, alcohol, nicotine, certain drugs as well that can lead to stimulation. Certain drugs, cocaine and amphetamines, things like that. Ritalin, that's commonly used now for studying and things like that. So these types of things could cause it, although there's no history of that. Medication, certain antiarrhythmic drugs can paradoxically cause PVCs. So, those are some of the things that can lead to it. Stress and anxiety, so emotional stress and anxiety, increased sympathetic activity, potentially causing PVC. So it may be worth it to check it with a younger person. They could definitely have emotional stress and anxiety. Especially, if you consider that Greta Thunberg says we're all going to be dead in the next 3 years. So I hope you guys are all walking to work and not using your fossil burning cars. But what I mean is there's a lot of stress out there for a lot of things, So those are some of the things that could be causing it. Hypertension. Now, we don't have a history of hypertension in this particular patient, but definitely if she was a hypertensive, that could be it. structural heart changes, idiopathic causes, so without an identifiable cause, and excessive exercise in athletes and things like that, So ventricular bigeminy, where PVC alternates with a normal beat, can be a manifestation of any of these causes, potentially indicating increased irritability or vulnerability in the ventricular myocardium. So that's what made this so interesting, because I can't remember seeing a ventricular bigeminy for quite some time. I think I remember maybe more than 5 years ago seeing one. So it's not a very common thing that you may see, but it's just to show you what it looks like. Now, ventricular trigeminy is more consistent with raised intracranial pressures and a few other causes, but ventricular bigeminy is more indicative of cardiac irritability if the patient especially presents with palpitations. So like I said, in this particular patient, we would get the patient checked out for electrolyte abnormalities, particularly high, calciums, potassiums, magnesiums. Because there's evidence of some ST changes, we could do our cardiac enzymes. We could have our patient ready should thrombolysis or PCI be indicated in this case. And in this case, if we really look at it, considering that AVR has a slight ST elevation, we'll be looking at the mainstem problem. So that could be quite serious, and the patient may well need PCI as compared to thrombolysis. Now, if all of that sounds a bit confusing to you, if you are listening to this, then I'd suggest going back and having a look at some of our ischemic ECGs so that you can actually have a look at that. I'll try and link one at the bottom so you can have a look at a mainstem mainstem ischemia, so that or mainstem occlusion, so that you have a better understanding of why we're saying that. And, of course, stress, anxiety, drug intake, stimulant intake, any of these things could possibly be the cause. Now, in the particular one, I don't think, by the time I had copied this, they were still arguing with it on the thread, so probably still have to go back and check on it. But like I say, I'm going to link to this at the bottom of the video. So I'd suggest, if you are interested in ECGs, they do a lot of good work. Dr. Rochelle, I hope I'm pronouncing it correctly. And really, there's some interesting ECGs that come through there. Alternatively, I also repost them on our X channel, Twitter channel. And yeah, I hope you guys enjoy that. Sorry for speaking a bit fast. I think I also had a bit too much coffee this morning, but I hope it made sense, and I hope it was interesting to look at it. An ECG that's not that common, but if you come across, can be very scary. But the main things to note are that if we were to have a P wave followed by this, we could say these were premature atrial contractions, or if you had an isolated P maybe. But, the fact that there's missing P wave with this QRS complex is what lets us know that this is a premature ventricular contraction. All right, and then you can always have a look at the causes as well. Okay, I hope you guys enjoyed that short presentation, and hopefully we'll have another one tomorrow. And yeah, I'm hoping to discuss something a bit more lengthy tomorrow. And yeah, let's see how it goes. Okay, keep well, and thanks again to all those who subscribed. Bye.